have never been more afraid than when they gave me that LDK. And then I went into that sweet, gentle night of the anesthesia. It was terrible. It was horrifying. So at personal experience, do not like it. In terms of patient-based experience, I've seen an elderly 82-year-old woman that I had to do a pretty complex ocular, like lateral canthotomy and canthelysis on, and I gave her ketamine. I gave her 5 milligrams. I remember it. It was low-dose ketamine. It was supposed to be an analgesic dose. Nope. Again, she became bradypneic, and then she went apneic, and she did not like it.
All right, let's go to the next myth. I love this. Somebody has severe pain. Like I broke my leg and they've never had an opiate before. They're 35 years old. If I give them an opiate, am I going to cause an addiction in the pre-hospital setting?
No. And I mean, the data that comes from this, I can talk about the American CDC. Yes, we need to be opioid conscious prescribers. Everyone does. Like any medication, there are risks and benefits associated with it. We need to try an opiate spare if we can. But if your femur is sticking out of your body, I think that merits an opioid analgesic. Certainly, we want to pick ones that have a lower addiction potential. We want to pick ones that are less euphoric. We want to pick the right agent for the right patient, the adequate dose for only the appropriate duration of time. Yes, those are all important prescribing principles, but the administration of a single dose when it is a indicated mechanism or indicated injury, again, is leading to more harm for the patient than less benefit. So we constantly do these harm benefit pro cons when we treat people, but illegal analgesia is not helping them long term. There's evidence to show that they have higher incidence of chronic pain, that they become more centrally sensitized to pain, which can further lead to chronic pain. So not treating someone because of risk, and I believe it's like a 3% risk from the CDC paper, that someone would need to go on either like opiate diversion therapy or have an inpatient treatment stay associated with opioids. But I don't think that warrants us not treating someone who's in acute pain. And certainly we can start with Tylenol and Advil as indicated. And then if they feel adequate at that point, great. If their pain is improved to a point where they feel that it is no longer severe or moderate, sure. But if they're still in excruciating pain, I need to treat that, either to help with extraction, either to make them comfortable for transport. There are all these reasons that we use these tools to get somebody where we need them to be. And it should be a tool that we use in the right setting.
I really like this, that depending on the patient, the circumstance, their injuries, like background, you could try Advil and Tylenol. Let's see how they respond. If not, I can move on to the next thing, that progressional step.
Yeah. It's a layered approach. It's step by step. It's what we do in the department. It's kind of how I was trained as a learner. And we'll talk about it, but it's the multimodal approach to pain. I'm going to start moving from non-pharmacologic towards pharmacologic. I'm going to move from low potency to high potency. If I can give Tylenol and Advil together, they'll be given together. And we'll hopefully get a better response to this person's pain. We'll treat that symptom.
So if we look at another subset of the population that's unequally affected by suboptimal analgesia, like unsheltered or those with substance use, like let's say I come in, I have a history of opiate use disorder, but I'm not using anymore. And I break my femur. If you give me fentanyl, and that's what I used to use, would you relapse me?
It's a discussion that I have with every patient. And this goes back to the foundations of like shared decision making. I can't administer a treatment without your consent to do so. And I need to disclose the risks associated with that. However, that doesn't mean I'm not going to treat your acute pain. And so it's certainly a discussion I have. If they ask me for opiate sparing therapy, absolutely, I will not give you an opioid. If they're hopeful that they might be able to, in this acute setting, that we might need to administer that single dose of fentanyl for extrication or for a short period of time, and they feel comfortable with that risk-benefit discussion that I've had with them, certainly I will administer that because they are in acute pain. And as we said, we need to manage that as a symptom. Yes, we'll treat with other things. It doesn't mean we'll only use that, but someone having a history of substance use, whatever that particular substance is, doesn't preclude them from being treated for an acute symptom as they're in front of you. That's my take. And I'm sure different physicians might feel differently about that, but it's always about what the patient needs in front of me. And it's on a case-by-case decision. And it's always with a discussion between me and the patient in front of me. Similarly, if someone is on, Ketamine or like opiate, or safe opiate supply, or they're on chronic opioids in the community, we know that those persons habituate to those opiates, that they might be receiving 60 milligrams morphine equivalent in the pre-hospital setting daily. That's their baseline. And now they have acute on chronic pain. They've fallen. They have an obvious extremity deformity. That doesn't mean that they don't need opioids. Like, we have this contraindication in the list that if someone has chronic pain, that they can't receive an opioid. But what we're seeing them for is acute on chronic pain. So we really need to think, yes, this person has acute pain. I'm not treating them for their chronic sciatica. I'm treating them for this femur fracture. So this might be a patient that I am then patching for and saying, hey, doc, this is what my patient takes pre-hospitally. We're a 45-minute out transport time on a very bumpy road. They have an obvious limb deformity. Can we talk about opiate administration, or can we talk about how to give them an opioid in this setting? Honestly, if someone has opiate use is on chronic opioids, that doesn't mean that they can't receive additional doses for the acute pain that they could be calling for. So it's really, anybody who's heard me about this, I always say, please patch. If you have a question, patch. If you have a question about analgesia, if you have a question about whether or not you can give this, if you're wanting to talk to the physician, run it by them, just patch. Like, I know there are certain, our offline medical directives are really prescriptive, but if their patient care is nuanced, and if there's a nuance and you have the ability to help the person in front of you, patch, have that discussion. So that's kind of how I would view treatment of somebody who's on opiates in the community, how I'd view management of their acute pain.
And if we look to, let's say, if someone's on opiates in the community and they accept the opiate and it's context dependent, do you have to give them higher dosages of the medication? And do you actually change what you're going to give them? Like, let's say they're on hydromorphine home. Would you go fentanyl? Would you go morphine? Like, you can see how this maybe gets more complex.
Oh, it gets very complex. And I start pulling out like the morphine equivalent calculators and looking at how many doses or how many milligrams we would need to give them, which for an acute dose or a breakthrough dose, which is based on what their total daily dose is. So it's certainly something I would defer maybe to the physician if you're patching for, to have them help work out, because it is going to be a higher dose if they are habituated to a certain opioid level. If, however, you know that this person takes a breakthrough dose of 5 milligrams of morphine, that's well within our skill set. And so that might be a little bit more nuanced. But for some persons that are on very high doses of opiates, we do need to look at morphine equivalents, because if we're giving them 5 milligrams, that's probably not going to touch their pain at all. And if we look at morphine dosing on weight-based dosing, we often underdose persons who are even opiate naive with 5 milligrams. So it's certainly not one size fits all when we talk about analgesic dosing, and it very much is about the patient in front of you. And there are a lot of factors that go into what dose is the adequate dose for them to give them an adequate analgesic response.
If we operationalize this, how do you actually give the morphine, we'll say? Like, do you do it in aliquots? Do you do it in slow push? How do you reassess?
I love an aliquot. First, it's a great word. Second, it allows you to titrate. If you have somebody, let's take it as an elderly person who's opiate naive, they might be exquisitely responsive to that vasodilation that comes with morphine. And so they're going to tank their pressures. And if I've just given a whole, push up front and not titrated it, and now I've bottomed out their pressure, not only do I have a patient in pain, but I have a patient in pain who now feels nauseated because they're hypotensive and wickedly vagal, versus giving that smaller dose and then redosing 3 minutes later if they wrote it out or tolerated it well. It allows us just to really mitigate any potential side effect associated. And anytime I do a procedural sedation, I use this line every time. We all have the spiels that we get into when we do the common consent stuff. But I would say I can always give you more, but I can't take any back. And so you might be an exquisite responder. So I'm going to go low and slow and see how we go. and then you kind of ride out what they need in terms of that analgesic. So I love an aliquot-based dosing. And anytime you push an opiate, it just doesn't feel good to the patient. I don't know if you've watched patients' reaction. I have, having given push dose of fentanyl and push dose of other things. If they're exquisitely responsive, you often get the hand to the chest or just this discomfort even associated with it going in as a quick bolus. So I like the aliquot, and I always like the low and slow is my mantra. However, giving them an adequate dose for what their weight is important. Sure, we can start in smaller 20s, 20, 20 to see if it builds. But I'm not only going to give 25. There's always got to be that reassessment for response.
That's such a good point because, of course, for our medical directives, if they're 18 years and older, you can give 25 to 75. But if you think approximatmately 1 mic per kilogram, then it's like, okay, they're 75 kilos. Let's do 75. If they're 50, let's try 50 and do it in small aliquots.
Yeah. Yeah. If we're just stopping at the 25, maybe that's the top up dose. Maybe that's the dose later. Maybe that's the patch back dose. But again, we want to talk about adequate analgesia. There was a paper that Russell McDonald and other co-authors did out of Orange in, I think it's a 2019 paper, and they looked at interfacility transfer patients looking at adequate analgesia, and they found that patients usually had an initial pain assessment done, which was part of their, I believe it's like their pre-flight checklist or their assessment. So they had their initial pain score done, and then they would give a dose of analgesia and then a reassessment. The majority of patients had no change in their pain score during that entire transport time. And what they found was either they weren't giving adequate doses, so they weren't adequately dosing the opioids that they were giving, or the interval of time between the dose and the reassessment or the redose was wickedly long. And so any benefit you had worn off. And so adequate dose for the patient in front of you, but also thinking about the duration of action of the agent you have in front of you. If you threw on that Tylenol and Advil beforehand, which we know can give us 6 to 8 hours, then we throw on the, that faster acting but shorter duration opioid to give, analgesia as we transport her through that particular extraction period of time while we get the non-pharmacologic agent of a splint on. Then it works because we've got the longer duration riding us out of the Tylenol and Advil. It's had time to kick in while we gave the shorter acting fentanyl, while we applied the splint that was a particularly more painful procedure. And now we have the splint on as a non-pharmacologic plus the Tylenol and Advil helping us during transport time as that fentanyl kind of tapers out in its duration of action. So I think this is where multimodal and multimodality pain management comes in. And also the right dose for the right person who's in front of you and titrating it to what their needs are. I feel like I'm saying the same thing over and over and over again, and I apologize. Similar principles.
No, but that just reinforces the point. It's like, this is all patient dependent. You should use multimodal. You have to titrate specifically to each and every patient.
Yeah, it's really understanding who's in front of you and what their needs are, and knowing what your tools are in your toolkit to how to best address that.
I know paramedics love this question, and of course, everyone has their bias and preference, but when do you pick fentanyl versus morphine versus ketamine?
Ketamine is its own. I'm going to put ketamine in its own category. It's the fun new tool, and it's fun. It's out there. It's novel. Great. I have seen a lot of bad come out of ketamine. Sure, there's a lot of good with it, but I've seen a lot of bad come with ketamine, and so I use it judiciously. If we look at the opiates, if we look at morphine and fentanyl, we know that morphine is the less euphoric agent, and it also is the one that might have a little bit longer duration of action, also a little bit longer time to onset. So I like to start with morphine if I can. If I need that right away onset of analgesia, though, I'm going to be reaching for fentanyl. If it's to facilitate extraction of a patient or manipulation of a fracture site, I might be reaching for fentanyl while we actually get the patient from scene into ambulance. If the patient is able to mobilize and it's an upper extremity injury and I've got time and they're not that uncomfortable as we splint and walk them over, I might be reaching for fentanyl. So I'm really thinking about within the opiates, their side effect profile quite similar. So I'm really thinking about what mechanics of this agent I want out of it. How quickly do I want it to start? How quickly do I want to be able to add more doses to it? And how long do I want that duration of action to work? Normally, morphine is what I'm going to reach for first. Again, less euphoric potential, easier to build on, longer duration, less euphoric potential, easier to build on, longer duration. So I'm reaching for morphine first. For fentanyl, it's usually for those quick procedures, quick on, quick off, cardioversions, things like that, or those procedures where I might want to build on dosing, like we talked about. It's an easy aliquot to ramp up to during that 25 reassessment. What I think about ketamine, as we said, new kid on the block. She's shiny and fancy. Low dose ketamine, LDK, analgesic ketamine, whatever you want to call it, is an interesting beast. I don't know if you've ever been K-holed. Do you know what K-holing? Do you know what a K-hole is?
The dissociative dose.
Yeah. You just put somebody into this really, really uncomfortable, terrified state. It is the dissociative dose, and it's not fun. I will do an aside here. I'll share it with the world, but I've had many surgeries recently. One of the anesthetists putting me under decided to use Presidex Presidex and ketamine to put me under, and it was a dissociative dose of ketamine, and I have never been more afraid than when they gave me that LDK, and then I went into that sweet gentle night of the anesthesia. It was terrible. It was horrifying. So at personal experience, do not like it. In terms of patient-based experience, I've seen an elderly 82-year-old woman that I had to do a pretty complex ocular, like lateral canthotomy and campholysis on, and I gave her ketamine. I gave her 5 milligrams. I remember it. It was low-dose ketamine. It was supposed to be an analgesic dose. Nope. Again, she became bradypneic, and then she went apneic, and she did not like it. So each patient responds uniquely to the agents that we give. Certainly, we can write out guidelines, which is what our medical directives are. We can certainly write out generalized guidelines for all comers, but each patient in front of us is nuanced. And my experience with ketamine is that when it's used in the right setting, in that traumatic patient, that patient where they have this acute onset of abrupt pain, often a traumatic mechanism, and we don't want something that is so hemodynamically labile as giving them an opioid, ketamine is an agent I'm going to reach for, and I'm going to start small. I might give 2.55 and build from there. Again, watching the patient in front of me, watching how they're responding to that agent. But it's certainly something that I'm cautious using because I've seen a lot of the side effects associated with it in my time in the trauma bay, in my time in anesthesia, in my time in the department. It's certainly something that a lot of emergency providers in their departments are even fighting for. The ability to give LDK in the emergency department is analgesia. And now we have it, now we'll have people coming in from our medics and they've already received LDK. So it's this interesting thing where often in hospital, we're actually fighting to get it and given in appropriate circumstances and patients are rolling in. So I think that's kind of cool that, the pre-hospital setting is adapted faster than some of the hospital-based settings. That's one nod that I like for it, but it's certainly something to be aware of, like the emergence reactions, the dissociative doses, K-holing somebody. There are vital sign associated hypopnea, bradypnea, apnea associated as adverse reactions with it. Not usually in the low dose setting, but it's just a tool, as we said, to be aware of what the side effects are. So ketamine is kind of its own beast that I like to think about off to the side. Again, used as an adjunct and used in the right setting. And then we talk about our opioids again. Over here, we need to be really aware of what effects we want for the patient in front of us and what side effects we need to know to mitigate as we're giving that. That was a very lengthy answer to your question, Ryan. I'm so sorry.
No, don't ever apologize. It was perfect because I didn't even prompt you. I kept it open for reasons, see where you go with it. But every single physician that I've asked that question to, they're like, ketamine should be respected. Because like you said, if I give you a dissociative dose and I put you in the K-hole and you meet the creator and I rip you out of that, you're going to be disoriented.
It was
agitated.
It was something else. It's having now had lived experience with that. It's as you said, it's to be respected.
And everyone loves to love it because it is new. And you hear the classic, oh, hey, brother, keeps them breathing, keeps their airway open. It makes it sound like you can just walk away and just be like, yeah, you're good. But no, everyone's like, they can stop breathing.
Well,
you have to be careful.
I feel like it's erroneous not to mention the Elijah McCain and everything associated with ketamine here. It must be respected. It is a sedative. There is a huge component of amnestic ability with this. We need to recognize it. Just because we're using the low dose or the LDK doesn't mean that someone might not be that sensitive. It is to be respected, as you said.
But that's the perfect kind of segue into the multimodal aspect of ketamine and giving it with an opiate, unless they're contraindicated, because that's the amazing education from the province that was sent out. It's like you should try to combine, hopefully in most circumstances, ketamine with opiate. Why is that?
It's interesting because a lot of papers haven't found that, there isn't that extensive or robust body of evidence that shows the combination of the two of them together is superior or non-inferior, depending on what you're looking at. Certainly, if we go towards multimodal, it's that the whole ethos behind it is that you're targeting someone's pain from different avenues, and that it would limit the amount of opioid needed to be used and limit the amount of side effects associated with it. So the combination of the two of them, ketamine and an opioid, such as fentanyl or morphine, may allow you to use lower doses of the opioid, which has unintended side effects, the hypotension, more reticent, more obvious respiratory suppression, things like that. So it allows you to combine an LDK with potentially a lower dose of fentanyl, whereby you might have wanted to use 75 micrograms initially. Now you can drop it down to 25 or 50 because you have the ketamine on board. So could allow you to do a little bit of opiate sparing, which is beneficial to patients. We know that. But certainly if you're layering ketamine on, I'm hoping if ketamine's in play, I'm hoping we're already at the definite severe category of patient's pain. Doesn't mean they can't take orals, but it might mean that they meet contraindications to getting orals, like being in full spine precautions or obvious bleeding or something like that.
Good. So opiate sparing effects, you should try to give it with an opiate. Try the opiate first. So overall, you reduce the amount of analgesic requirements overall.
Well said.
Then, correct me if I'm wrong with this, because the systematic review, I forget the authors, but basically they said ketamine should be given in the pre-hospital setting, especially those with burns, severe burns, traumatic amputations. But we're not trying to dissociate them. You're not trying to sedate them. You're just giving analgesic dosages, because that's a common misconception. It's put them out. I've lost an arm, put them out. And you're like, no.
Do not. Yeah, that's a great point. I think that's why I call it LDK, low dose ketamine. Is for myself, it's a different adjunct than it is ketamine when I use for procedural sedation. They're really two separate entities. I'm using my ketamine in the analgesic range, which is very, very much smaller doses than I'm thinking the 0.5 to 1 to 1.5 1.5 milligram per kilogram dose in terms of the procedural sedation avenue. These are different agents, and they need to be treated differently. You do not want to sedate that burn patient and lose that airway, right? This is not what we want. We want to use it in the appropriate dose. So the 2.55, whatever, the LDK, low dose ketamine, is for the pain, not a sedative aspect. And that's what I mean, when you really need to know the patient in front of you and what the desired effects of that tool are. Just because you have that, huge sledgehammer doesn't mean that you need to use it in that context.
But you mentioned ketamine in the elderly, because that's a high-risk population. But let's look at the opposite end of the spectrum. Ketamine for pediatrics, even for analgesia. What do you think?
I mean, ketamine in pediatrics, most of us love as emerge docs, because that's our safest agent for sedation, procedural sedation. Ketamine in the pediatric patient population, I don't know if I have as much experience or I've looked into the data as hard as I need to come down hard and strong on a recommendation here. When we think about the young adult population, which is our most common trauma population, it's great in those 18, 25, 30-year-olds that are doing these mechanisms that necessitate a pelvic fracture rather than the cause of pelvic fracture and an open fracture. Ketamine's great in the trauma bay. We love it. We have ample experience in that context. If we're talking about the 3-year-old who's got the open fracture for low dose ketamine or analgesic dose ketamine, I don't have the experience behind that to be that's what I'm reaching for. In that population, it's certainly someone that I would be considering using our fentanyl directive and patching for that and getting the adequate dose for the fast onset and the predictable course that will provide. Because kids and analgesia, kids and IV medications, it gets a little squirrely. Each kid kind of does their own thing. You know, if we think about kids, pediatric population, benzodiazepines, like they do wild things on benzos. They have those paradoxical reactions, right? It's certainly something I don't have as much experience as I'd want to give a hard recommendation on whether or not I'm going to be using LDK for that pediatric kid.
That's such a cool answer and such a genuine answer. Because, of course, the medical directive speaks you can patch for ketamine under 18 years old, and that's the specific reason why that's a patch point in there. But you said, like, I'm not even comfortable with me giving it. And you think paramedics are like, oh, Ryan taught me this CME, a crash course on ketamine. Why don't we try it? But it's like, we have the opiates first for probably a reason, and then they're probably the better, safer option.
We do. And I mean, like, I would never speak on behalf of all the base hospital physicians of Ontario, but I certainly think that it's a common, it's a place where we get a little reticent with it when we're giving LDK in the peds population. And I mean, even the pediatric experience of the base hospital physicians that a lot of times you're patching for. If I think about my base hospital and the physicians that I get to work with at the Brook, we don't see a lot of pediatric patients. I have the awesome benefit of also working out of RVH as my main site, and peds part of our bread and butter. And so I see a lot of pediatric population, and I'm really comfortable with analgesia and sedation in that demographic. But when I'm at the Brook and I'm working with my colleagues and listening to patches and things like that with my colleagues, peds aren't our bread and butter there. So for someone to patch being like, hey, can we give some ketamine for this 5-year-old? I don't know if you're going to get that patch right. I'm not saying don't try. I just don't know what that outcome is going to be. And it'll be interesting to, I think, to see what happens with our ketamine directive, particularly in that pediatric population for that LDK. It'll be an interesting QA that I'm sure one of the base hospitals or all of us will do in the coming years.
Are they at higher risk to losing their airway or losing their breathing if we give them ketamine?
It's a great question. I don't think so, based on the fact that we give significantly higher doses in the pediatric population for sedation. We're leaning towards like a 1 to 1.5 mg per kg dose, obviously titrating as we do. And we don't see apnea, or we start to see other gnarly sequelae like wicked secretions or, oh my gosh, I'm not going to think of it, but Larson's point is used to break it when they lose.
Laryngospasm.
Thank you, laryngospasm. I was like, it's going to evade me right now. I've seen laryngospasm. It was terrifying. I used propofol to break it. I respect ketamine, as we say. I won't do my procedural sedations without having an IV in place now for my pediatric population because of that laryngospasm I saw. So I don't think per se they're at higher risk of losing their airway. But I just think it's a huge population that we're a bit more reticent to be trying novel agents in.
What does the hypersalivation look like, and how do you treat that?
Suction, suction. I've only seen it in the operating room, and again, a wickedly controlled setting. But certainly, there was a lot of suction associated with it, and it wore off by the time the kid was awake. It was also what we saw a little bit as he was kind of coming out of his reaction.
Because we taught that, obviously, and they're like, what does it actually look like? Because I haven't personally seen it. I've heard like infrequent times it happens, but yeah, it's just suction, look kind of like they're frothing at the mouth a bit and excess secretion. So
yeah, they become very moist. I don't know. There's a lot of secretions.
And the next question, which you love, is that, well, should I patch for atropine or glycopyrrolate for that?
No, we're good.
Old base hospital. Yeah.
Yeah.
Just suction.
Yeah. Just suction. Yeah. 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 And that goes back, just because we have the tool in our tool belt doesn't mean we should use it. And a lot of us are super conservative with the peds population. If you can ride it out with the non-pharmacologic, ride it out with the non-pharmacologic rather than adding on that other adjunct and then having to deal with all the sequelae of what that other medication brings. And then we just start snowballing with what we're trying to treat with just ride it out with your yonker or your hand or your mat, whatever.